checkpoint inhibitor has been approved for gastric and GJ adenocarcinoma, esophageal squamous cancer, and MSI-high tumors, including colorectal cancers. First, MSI-high is the most distinguished important biomarker to predict the efficacy of checkpoint inhibitors. MSI-high or MMR deficient can induce many frame shift or missense mutation and expression of neoantigen. And in clinical trial for colorectal cancer, Keynote 177 trial showed a very significant PFS benefit in MSI-high patient by pembrolizumab, and now pembrolizumab is become standard of care for such patient. Also, subgroup analysis from at least 3 randomized studies in gastric cancer also showed a remarkable efficacy of checkpoint inhibitor for MSI-high tumor. So this must be most important biomarker, and we shouldn't forget to test. And the second is PD-L1 expression. PD-L1 inhibitor target PD-1 and PD-L1 interaction, so it is very reasonable to evaluate PD-L1 expression in tumor cells as a possible biomarkers. On the other hand, the PD-L1 is also expressed in surrounding immunocells such as lymphocyte or macrophage, so combined positive score or CPS can take into account for both PD-L1 expression in tumor cells and immunocells. In gastric cancer, CPS is more predictive and useful to predict efficacy. For example, Attraction 2 trial in later line setting did not show any predictive value of tumor expressing PD-L1. But in Keynote 61, Keynote 62, PD-L1 CPS is predictive, especially CPS less than 1 in Keynote 61 showed worse survival compared with second-line paclitaxel. In contrast, CPS 10 or higher showed some enrichment benefit. So also in meta-analysis, hazard ratio was 0.95 in CPS less than 5, suggesting no benefit. In esophageal squamous cancer, not only CPS but also tumor PD-L1 is also considered as a biomarker. TPS 1 or higher, or CPS 10 or higher is a possible appropriate cutoff. But the benefit was still suggested in CPS low or TPS low in squamous histology with a hazard ratio of 0.8. So this is different from adenocarcinoma because generally tumor response for checkpoint inhibitor is better or higher in squamous histology than adenocarcinoma. So CPS seems to be useful to exclude patients without benefit in adenocarcinoma, and actually NCCN guidelines recommend chemotherapy and nivolumab for CPS 1 or higher, and chemopembro for CPS 10 or higher. But there is actually uncertainty of CPS by interchangeability of different antibodies, low CPS in all the tissue, and spatial and temporal heterogeneity. So quality assurance in each institution or laboratory must be important. If this is not feasible, all-comer use is possible approach. So again, MSI-high, CPS, PD-L1 in GJ adeno, and CPS and TPS in squamous histology are already one of the standard of care. And the third biomarker is tumor mutation burden, TMB status. In gastric cancer, TMB high is overlapping with MSI-high, but still around 5% of patients has TMB high status. And some trials such as Checkmate 609, Keynote 61, and Keynote 62, TMB high and patient with MSIS still show the enrichment of the benefit of checkpoint inhibitors. In contrast, TMB low and CPS low show the worst benefit. So this TMB is also some helpful biomarkers, but there is still debate about the optimal level of cutoff and the TMB value, especially outside the MSI-high tumor. And there are other possible factors for checkpoint inhibitor, including immunophenotype in tumor microenvironment, RNA signature related to angiogenesis, or stroma-related signatures. And finally, relationship between this factor and response or resistance was suggested in some study like Keynote 61 and Checkmate 69, but still we need some validation in additional studies.